Welcome today's webinar on management of COVID-19 in immunocompromised vasculitis patients. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational video series, and I'm also a patient living with vasculitis. I was diagnosed with ANCA-MPA in 2008, and I was in treatment for 6 years, and I'm extremely grateful to have been in remission off treatment for 8 years. But before we start today, I'd like to remind you that today's webinar is for informational purposes only, and it's not meant to replace your physician's advice. And I think I'd like to begin today by introducing our two physician guests for today. We have a really unique guest panel, a father and daughter who are both rheumatologists at Cleveland Clinic. And so I'll start by introducing Dr. Leonard Calabrese. He's a professor of medicine at Cleveland Clinic, Lerner College of Medicine. He's the R.J. Basenmeyer Chair of Clinical Immunology in the Department of Rheumatic and Immunologic Disease at Cleveland Clinic. And Dr. Calabrese is also the co-director of the Center for Vasculitis Care and Research and has a particular interest in vascular inflammatory disease of the central nervous system. And his daughter, Dr. Cassandra Calabrese, is an assistant professor of medicine at Cleveland Clinic, Lerner College of Medicine, in the Department of Rheumatologic and Immunologic Disease and the Department of Infectious Disease at Cleveland Clinic. So welcome to you both. Thank you so much for spending your time with us today. I think the best thing to do at this point is turn it over to Dr. Cassie Calabrese at this time so she can share some information with us, and then we'll follow up with all the questions we've gotten from patients while we were gathering them for this webinar.
Thank you so much, Kathy. We are just honored to be here to have the opportunity to share information and answer questions about COVID in immunocompromised vasculitis patients. Since the start of the pandemic, there's been so much information and so many changing recommendations, and it can be really hard to keep up to date with what's new, what's recommended, including vaccines and treatment. So we just wanted to start out with a couple slides kind of overviewing what is the latest in recommendations for management and treatment of immunocompromised vasculitis patients who get COVID. To start, I think this is a really important concept. Where are we now and where are we going with the COVID-19 pandemic? And while for a lot of people, like people who are not immunocompromised and are vaccinated, the pandemic may ultimately fade away, and they're in a pretty good place right now. And people who are immunocompromised who might not respond as well to the vaccine and might have many risk factors for having more severe COVID if they get sick, the pandemic's not likely so much to fade away for them. And while things are getting better, we always need to focus on these high-risk patients, and it's that group that needs to be focused on for lowering risk and knowing what to do if you do get COVID. So it all comes down now to the concept of breakthrough COVID-19. This is infection after being fully vaccinated, breaking through the protection of the vaccine. And this is what we're talking about now. Yes, healthy people can have breakthrough COVID, but people who are immunocompromised, and it depends on what drug and your other risk factors and comorbidities, have much higher incidence of having breakthrough COVID, and also potential for progressing to severe disease compared to someone who is not immunocompromised and on medicines to treat vasculitis, for example. So just starting with an awareness of what breakthrough is, knowing that you can still get sick despite being vaccinated, and what symptoms to look out for with all the currently circulating variants, Omicron, 2 point whatever is the latest, it can present as upper respiratory tract infection-like symptoms that many patients mistake for a cold or allergies. So just even having that awareness and knowing when to get tested and talk to your doctor is really important. And we envision kind of this circle of care for high-risk immunocompromised patients, starting with an educated patient who knows when to be aware that they could have COVID, or if they were around someone with COVID, knows what symptoms to look out for, and then knows how to test themselves, including having rapid home tests at their disposal. These are the rapid antigen tests that you can buy at any drugstore, and that every patient should have a stack of these at their home and know what to do with them. And then also knowing who to call. Patients with vasculitis and other complex rheumatic diseases often see a lot of different doctors, and sometimes they aren't sure who's kind of the maestro of their care. So important to know which doctor to call. And then it's important that your doctor knows what to do. And with the changing information, this can be difficult. So it's also important that you know what to do too, and what's out there to help protect you and treat you. So a couple points about risk of getting really sick with COVID. And patients with vasculitis and patients on immunosuppression have two challenges. There's increased risk for getting really sick due to the medicines that you might be on that suppress your immune system. And then there's also increased chances that your vaccine didn't work as well because of the medicines that you're on. So kind of a double-edged sword. And we highlight rituximab here because of all the drugs we use in rheumatology. This is at the forefront for being responsible for both of these negative effects, including severely reducing the vaccine effectiveness, as well as being on rituximab increases your risk of severe COVID. So we'll kind of highlight patients on rituximab as being in that highest tier of risk for getting really sick if you get COVID, even if you're fully vaccinated. So what's in our toolbox for treating immunocompromised patients who get COVID? Fortunately, over the past many months, there have been great developments, and we have lots of things at our disposal to treat COVID patients as outpatients, including oral antivirals. This is kind of similar to the antiviral you would take if you got the flu, like Tamiflu, when you get sick and you take it, and it helps reduce symptoms and reduces risk of you getting sicker. So Paxlovid is what's being most widely used. And there's also a second oral antiviral called molnupiravir. These all are indicated for patients with risk factors for progression to severe COVID-19, including even just if you're 65 or older and have nothing else going on, being on immunosuppressive medications, having diabetes, chronic lung disease, et cetera, et cetera. They're available by prescription only. They must be prescribed within 5 days of symptom onset. So that's when they work best. And their goal is to reduce the risk of progression to severe COVID-19, like needing to be in the hospital or on a breathing machine. Other tools at our disposal are monoclonal antibodies. This bebtelovimab and other similar drugs that are also hard to pronounce are monoclonal antibodies against the spike protein of the virus. And they, when given as an infusion to someone who has COVID and is not in the hospital, they reduce the risk of progression to severe disease. And these need to be given within 7 days of symptom onset. So these are things important for you to know that exist, and also for your doctors to know that these are at their disposal to treat you should you get sick with COVID. What about preventing COVID in immunocompromised patients? Vaccine, of course, first and foremost, is recommended for everyone. And for immunocompromised patients, the recommendations are a little different. This has been a huge source of confusion since the start of the pandemic with vaccines available. So everyone should get an initial 2-dose series of one of the mRNA vaccines, which is Pfizer or Moderna. And then everyone who's immunocompromised is recommended to get a 3rd dose. And the timing of that is at least 28 days or more after your 2nd dose. And this is very different than the recommendations for people who are not immunocompromised. And then the latest recommendations for a booster dose, so a 4th mRNA vaccine, are for that to be given at least 4 months after the last vaccine. So this is what's recommended for everyone who has an immunocompromising condition or drug. And, the timing of the vaccine is really important in patients on certain immunosuppression. As we mentioned, they can reduce the effectiveness. And this is most important for rituximab patients. It's best to wait as long as possible after your last rituximab infusion to get a COVID vaccine, and then wait like 2 to 4 weeks before your next dose. It's not always feasible, but that's what's recommended to maximize chances of having a good immune response. Perhaps most exciting, and the last drug I'll talk about, is called Evusheld, or tixagevimab, silgevimab. Like the monoclonal antibody I mentioned on the slide before, this is a an injection version of that type of monoclonal antibody given to prevent COVID. So you get it because you're high risk, including everyone on rituximab and many other patients with other risk factors, including, being on high dose steroids and a lot of other drugs we use. This is given to prevent COVID. And this is something you should definitely talk to your doctor about. And it has long lasting protection, significantly reduces risk of developing COVID and severe COVID over many months. We're very excited about that. What we tell our patients now, we see many patients on rituximab. We tell them they're unlikely to have had a good response to no matter how many vaccines they've had, unfortunately, and should be counseled appropriately. And this is the group that should really be highlighted to get that Evusheld drug. And also this group and many other immunocompromised groups are ones that need to know to tell their doctor if they have COVID concerns, test themselves, and receive those antivirals or monoclonals if appropriate. All patients should be fully vaccinated with 3 mRNA vaccines and then a 4th dose 4 months later, where appropriate. And for patients to be aware of breakthrough, to have tests at home, and to know who to call. I feel this is very important. So hopefully that unmuddied the waters a bit. I know there's lots of other good questions to get to, and we look forward to answering them.
That was great. That actually did cover quite a few of the questions, but I think as with everything else, it brings up other questions. So I'm going to try and dive into some of the patient questions, and Dr. Cassie or Dr. Len, whichever one of you wants to answer them would be great.
Great.
I think one that comes to mind that was pretty much what you were just talking about was how long is the effectiveness of Evusheld, and do we know if it's good for 6 months or 3 months? And I did hear what you said about when to get it, but maybe answer that one.
That's a great question. One of my vasculitis colleagues was just asking me this question, but moments ago. I didn't get into the weeds about the dosing, but when Evusheld was initially authorized for use now many months ago, the emergency use authorization, which is not FDA approval, it's how vaccines and things have come about for COVID, it was recommended to get an initial dose and then a redose 6 months later, because the initial data showed it was effective for around 6 months. The problem with all things COVID is that study was done many variants ago, and now we have Omicron and Omicron subvariants, so we don't know how long it lasts yet. And actually, in the end of February, they removed that recommendation from the EUA for Evusheld. So at present, there's no recommendation to redose Evusheld, but there will be a statement and guidance on this forthcoming very soon, I'm sure.
Probably before 6 months.
Yeah.
Okay, great. That's a good thing just to tell patients, just what Dr. Len Calabrese just said. Probably before 6 months, we'll have that answer. And for right now, it's taking care of us.
Right.
How about what are the main considerations and risk benefits of determining if a patient should receive Evusheld? I think one of the questions that came up is, if you're immunocompromised, but you're not on rituximab or something similar, is Evusheld administered?
That's also a very good question, and one that was a great source of debate kind of earlier on when it was first authorized, and we had very few doses. Now we actually have a lot of Evusheld across the country, and many doses that aren't even getting used for a lot of reasons. But the way we first triaged and created our criteria here at the Cleveland Clinic of who should get Evusheld, certainly not every immunocompromised patient needs Evusheld. We looked at risk factors that we know portend bad outcomes. So drugs or conditions that are associated with doing really poorly, like being in the ICU or potentially dying, which is not, we now have data on a lot of the drugs we use, and that's not all of our drugs, but what stands out is rituximab and drugs like rituximab. So we put that at the forefront. Patients on rituximab, patients with other humoral immune deficits, like patients that need IVIG regularly, patients with cancer, receiving chemo, transplant patients, and then moving down kind of the drugs we use in rheumatology. There certainly are various combinations, plus other comorbidities like being older, having lung disease, where we consider giving Evusheld, for example, like an older patient with lung disease on Cellcept or high-dose steroids and methotrexate or something. There's, you could argue that a lot of people need it, but we focus on patients and risk factors and drugs we know are associated with getting really sick. And rituximab is the first and foremost. Cyclophosphamide too. There, are less patients receiving that drug, and we don't have a lot of data, but chances are it's not good for your COVID either. So any kind of high-level immunosuppression or multiple comorbidities.
Understood.
There is a blood test to see whether you have made an antibody response to the vaccine. And while there's some controversy about its use, we've learned that if you don't make any antibody, you're vulnerable. So for people who aren't heavily immunosuppressed, if you're on rituximab and you've had it within the past year, you should be on Evusheld. There's absolutely no doubt about it. For other people, the vast majority of people will make some antibody response. And if there's a question, the doctor can order the anti-spike protein. If you have any, there's a level of protection. If you have none, Evusheld.
Yeah, that comes up a lot. And patients usually have lots of questions, and doctors too. And while we still don't know how to fully interpret a positive antibody result, if it's negative, that's not good. If you're immunocompromised, that's what we can say for sure.
Yeah.
Understood. Good thing to know to ask our doctors about. I think I'd like to ask Dr. Len Calabrese this question. This patient asks, what are the 3 things that surprised you the most from the COVID pandemic?
Today?
Well, I guess it could be any time over the course of the pandemic.
All the days.
All the days, yes.
I don't know. There's about a million things. I would say that I'm surprised that patients with immunosuppressive illnesses and who are on biologic therapies other than these B-cell depleting therapies do pretty darn good. And that's a good thing to be surprised about. I'm surprised that so few people who are heavily immunosuppressed who get COVID-19 are actually treated with the therapies that Cassie talked to you about. That's a bad thing. And I think we got to do much better. And then, I don't know, surprise of the day is probably
preparing for future surprises.
Preparing for future surprises.
Right. That should always be the big deal.
Right.
This is interesting because the next statement says, I'm a patient currently in remission with vasculitis. Well, that could be me. I'm fully vaccinated, but I'm worried that I could go into a relapse if we keep having to get boosted. Is this a concern or is it unfounded?
Well, I think that by and large, autoimmune diseases rarely have serious flares after vaccinations of any sort. So I will tell you that still vaccinations are important. Secondly, COVID flares of vasculitis have been reported occasionally after vaccines, and they've been reported occasionally after COVID-19. And, which is worse, they're both significant. On the other hand, not being vaccinated when you can make a response puts you at far greater risk in this pandemic, where virtually everybody's going to get COVID sooner or later, of a very severe outcome. So the odds are to get vaccinated, and I think the risks and benefits are in favor of benefits.
Of getting vaccinated.
Yeah.
Agree.
Yeah.
Well, That certainly helps me to understand. I'm fully vaccinated, but that helps to know. Do vaccines for patients on Rituxan, since that's like the most common question we get, do they receive any benefit if they hold their rituximab for 9 months? And the second part of that is, do T cells help with the vaccine effectiveness?
All right, these are questions that require a lot of hand waving to answer, and there's really no solid answer. I will tell you that being vaccinated less than a year from your last rituximab is still a very high risk of non-response. And holding the rituximab to be vaccinated versus being on Evusheld, I think is a really delicate argument. You don't want to. You need to have as much rituximab as you need to control your vasculitis. That's what is needed, and you and your doctor have to map that out. It's very, very important. Some people who haven't had rituximab in a year, they're in remission. Going down the line here, then your chances of vaccine response are pretty good. But you need to make decisions about your vasculitis first, vaccine second.
They asked about T cells.
T cell, this is a work in progress. We have strong feelings on this, and there's not enough data to say that if you've been vaccinated within a year of rituximab, we don't think that these T cell responses are doing a whole lot.
Understood. Do either of you have an opinion about the possibility of the vaccines waning over time? Like, how people want to know, how long does the second booster last? What's its peak efficiency? I think they're asking because if they're going to travel, they're trying to time that to what its best efficiency is.
Yeah, also unanswered questions. We don't have very much data at all on duration of the fourth vaccine because people have only recently been getting those. But after the third vaccine, most data would suggest the kind of 3 to 4 months after that vaccine is kind of peak effectiveness, and then it will wane.
Just to add to this, I think that people who are immunocompromised and people who have had rituximab should live a life. And at the present time, in the absence of being able to answer all these questions, let's not ignore and forget about non-pharmacologic interventions. People who are traveling, if you've had rituximab in the last X number of years, if you're traveling, you need an N95 mask, particularly in the plane and the airport. You're outside and hanging out, that's great. You go do this, but that's a layer of protection that no one can tell you is not a good idea.
Well, I love that answer, and I'm happy to say I just traveled internationally, and I wore my KN95 the whole time, and
good for you.
Poster child.
Model patient.
Came back perfectly healthy, so that's a good thing. I sincerely appreciate the time that you spent with us today. These were big questions, a lot of them for me, so I'm sure they are for so many other patients, and I appreciate you giving us this time today. And we will put out your Twitter information because that will help people.
Oh, we love it. Thank you.
It was our pleasure. Thank you.